So good afternoon, everybody. My name is Dr. Beth Filan. I am the Assistant Director of the NIHR Yorkshire and Humber Patient Safety Research Collaboration. And we are delighted today to welcome you to the first of this series of Safety Net seminars. And we're even more delighted to be welcoming Professor Charles Vincent to give this first seminar on safety strategies for the short and longer term. So Professor Charles Vincent is a Professor of Psychology at the University of Oxford, and he has since 1985 been conducting research focusing on the causes of harm to patients, the consequences for patients and staff, and methods for improving the safety of healthcare. He's the author of numerous books and papers on medical error, risk, and patient safety. His previous roles have included establishing the Clinical Risk Unit at the Department of Psychology at the University College London. He was the Director of the National Institute of Health Research Centre for Patient Safety and Service Quality at Imperial College, and he was the Commissioner on the UK Commission for Health Improvement. In addition, he's acted as an advisor on patient safety in many inquiries and committees, including the Bristol Inquiry, the Parliamentary Health Select Committee, and the Francis Inquiry and the Berwick Review. And his recent work has developed methods of studying and improving patient safety in community settings, ways of measuring and monitoring safety in the NHS, and studying how regulation in healthcare contributes to safety, and also how it can potentially stifle safety improvement. But Charles is also the co-lead in our Yorkshire and Humber PSRC in the theme around supporting safe care in the home, which I know is a new area that Charles is really focused on developing safety solutions for. So just moving on, before I hand over to Charles, just some brief housekeeping. We'll be taking questions at the end of this seminar. But if you do have any questions in the interim that you want to keep track of, please do put them in the Q&A, and Debbie Clark will be monitoring those and putting those to Charles at the end of his seminar. So without delaying further, I'm going to hand over to Charles to introduce himself and the seminar he's giving today.
Okay, thank you very much, Beth. Let's see if well, thank you. Apologies for the coughing. Well, it's a pleasure to be here, and I've had a long association with various PSRCs, particularly obviously to Imperial. And now it's a great pleasure to be linked with the Leeds theme. So I'm also really pleased that Safety Net exists. We always tried to collaborate a bit earlier when there were fewer PSRCs, but I think it's a great strength that there's much more effort now to do things across the different groups, and that there's more of them too is also a very good thing. So I'm going to talk about safety strategies. I think this is mainly a research audience, so this gives me a chance to talk about things in the, if you like, in the way I think about them. And I'm going to try and persuade you, if you like, that thinking in terms of frameworks is helpful as a way of thinking about interventions. And some of this comes from attempts made by Rennie Amelberti and I in a book and various papers to think about how different safety strategies could be implemented, but also what forms they take. You know, we hear a lot about human factors, resilience, quality improvement, and one of my questions was, well, how does all this fit together? Can we find a good way of thinking about it? But recently, with the increasing pressures on the healthcare, we also have to think about short-term strategies as well. So I'm going to try and include a little bit of that as well as we go through. And as Beth said, I'm going to keep to 40 minutes at the most, and to make sure we've got some time at the end. And I'll jump ahead of myself a bit if I need to, in order to keep to the time. So this is the overview of the talk. safety frameworks. I'm going to try and talk about why I think they're important. And then some introductory work on the varying levels of care, how we look at safety in different contexts. And I'm going to talk about what I call a portfolio of interventions to build safer systems. And that I think this is the way we have to think about this as a portfolio, not just a sort of one intervention at a time. And then also to think about the shorter term adaptive strategy. So let's just think a little bit about frameworks. I'll just show you a couple of frameworks that I and colleagues have developed over the years and explain why I think it's useful to have. I think model is a bit too strong a word here, but framework for me is a way of organizing things and using it to make decisions and to think not just as a researcher, but as a practical person trying to put this into practice in the NHS or other systems. So here's one earlier framework from the long time ago now, the framework for analyzing risk and safety in medicine we developed in the 90s. And this is a framework of contributory factors, which are really influences on the process of care. And we broke this into 7 groups, now 8. I won't going to go through this, but this has been used in a lot of different studies, for instance, by Brian and Dean Franklin on medication errors and various other things, and also to develop methods of incident analysis and to categorize and systematically think through the different influences on a patient journey, on the causes of an incident. Here's another one, which is very different. It's about how we know whether an organization is safe. What does it mean when a non-exec or somebody says, well, just tell me if we're safe? And it was clear when we did this that there wasn't any sort of consensus about even what that question meant. So this is the framework to say, well, you've got to look at different facets of safety in order to give a sensible answer. It's the past, reliability, the current situation, and so on. So this is another sort of framework that gives you an organizing principle for addressing all sorts of things and to making also practical changes to the way you run things. And in Renee and I, when we're writing this book, Safe for Healthcare, which is available, it's a free download, so it's easy to pull off almost everything I'm going to say today. We're thinking about interventions to improve safety, and indeed actually to improve quality too. We wanted to think, could we develop a generic framework that we could use across different contexts? I'm not sure that we succeeded, and certainly we didn't sort of push it hard enough into practicality. But we did have some success in putting the general ideas together. And this is what I want to share with you before I shift onto the more recent work about the short term. May seem a bit counterintuitive doing the long term before the short term, but I think the long term things are more familiar and it'll be easier to do it this way. So some background, I think. Patient safety was initially conceived partly in terms of harm, but the harm was viewed as being due to errors. And although that's still a perfectly reasonable vision in the sense of that there certainly are errors, there's an argument about how you interpret them. But the thing is that the problems and the difficulties and the errors are so frequent that it's not so much one particular error, but the dangers to patients come from a more generic sort of failures in care, if you like, and not just the actions of people, but the sort of problems of systems, as we all well know. So this is from some earlier work we did at Imperial and other places, just finding that operations often start, without the right equipment. And I'll come back to that later as a theme. So you wouldn't run a coffee shop like this, but this is quite routine and not just in the NHS, that the situation that people work in is far from ideal. And the challenges and the sort of outcomes for patients. So Rennie and I tend to think about, we divided care rather randomly, just to give a sense of this, that care is always, the standard of care, if you like, is always moving around. You can be in an operating theatre or a clinic or something and everything's running perfectly fine at 2 o'clock in the afternoon. But by 4 o'clock, there've been problems. There's problems in intensive care, there's equipment problems, tempers are getting a bit frayed in the operating theatre, and the whole situation is a great deal more hazardous. And this just represents the sort of how well care is provided. At the top, it's very optimal. And then number 2, if you like, is just ordinary small things going wrong. Number 3 level is what René calls the illegal normal. Small things are always not being done quite correctly. And some of the care is not quite properly, but there's no actual harm. And then you get down to the sort of more dangerous levels for patients. And part of our thinking is, and as I'll show you, that the interventions we need to make care optimal, which is sort of to improve quality, if you like, may be different from the interventions that we need to manage the risks, the tail end of the distribution. And this distinction, which is quite hard to evidence, I think, but has been rather lost over years as most patient safety interventions have sort of morphed towards basically being quality improvement. And I'll develop this a bit more in a minute. Now, from this, the other thing is that we need to think about in advance. There's more of this in the book, but it's about interventions in different contexts, and that safety is approached and achieved, this is a better word, achieved in very different ways in different contexts. And this helps perhaps make a bit of sense of the endless arguments about aviation and whether it's a good model or not, and whether it's anything like healthcare. So aviation is one way of approaching safety in nuclear. And René and I call this approach ultra-safe, in the sense that it relies very heavily on automation, on very standard procedures, on an orderly way of doing things, a lot of training, very strict regulatory systems usually, and basically an approach where you exclude risk as much as you can. If the plane's not ready, you don't take off. If the weather's bad, you avoid it. You exclude risk. And that's fine. And it produces, very, very safe system. But a different approach, which is required by the context more than anything else, is safe firefighting, for instance. Now, I'm no expert on firefighting or anything about it, but you can see the general idea is that risk is, you can't avoid risk if you're firefighting. It's not sought out, but it's inherent in the business. It's also a much more fluid situation. People are familiar with there are certain types of fires that they can become familiar with, but obviously everything is there's always slight changes, slight variations in where you are. And the way they approach safety is partly by standards and procedures, but an awful lot by flexible teamwork and having prepared routines and so on. And here's another example of deep sea fishing, which René's worked on, which is highly individualistic. Obviously, people still want to be safe. They're not mad. They're just doing something that's very dangerous. It's much more unstable. You can't predict what's going to go on. And as René says, it's a cult of champions and heroes. It's very much a sort of individual leadership, charisma, and personal resilience. Obviously, people still try and look after each other and care about each other and help them, but it's not formal teamwork in quite the same way. So what's the relevance of this to healthcare? It's really that we have all of these in healthcare. I won't go through this diagram in any detail, but very broadly speaking, we have radiotherapy, blood transfusion, and things like that. Although we've had recent problems, dating from the 70s in blood transfusion, they are ultra-safe systems, and automated pharmacy, things like that. They have all those sort of characteristics of the ultra-safe. An awful lot of it is in the mid-zone of the firefighting zone, if you want, which we've termed high reliability rather loosely, where you approach safety in a very different way, and your possibilities for the way you can work and make things safe are different. And sometimes, as in COVID or in very unusual sorts of diseases or something, we also have the ultra-adaptive. And a lot of progress in safety and indeed efficiency comes from removing, say, something like cardiac bypass. In the early days, it would be in the ultra-adaptive sort of situation. but gradually it's moved more standardized, more routine, more towards the ultra safe. And there are difficulties of different kinds of working in all these contexts. But you can see that when you think about strategies, you might want to think about different sorts of strategies being appropriate in different contexts. And this is part of the background of thinking that we need, I think. So what are these strategies and interventions? And these are all long-term things in the sense that they may apply day to day, but these are things that you try and build in over the long term and are subject of our plans and interventions and initiatives. So I'm going to go through the 5 families, as we might call them. These are families of safety interventions. Within each of these, there are a lot of different strategies, very particular sort of types of approaches. So the totality of the things we can do to improve safety is considerable. And there's a big table in the book, which I won't show you, considering a very large number of different things that we can draw on, but generally don't. So for this reason, it's quite helpful to have a frame and to think, well, you know, we've got a situation here, a problem or a research project. What are the broad approaches that we can bring to bear on this? Let's think through this systematically. So let me give you some example to try and illustrate the strategy. And I'm going to use partly sort of richer systems and a couple of examples from Kenya and places like that I work on with a colleague who works in low resource settings. So the most common approach to safety, basically, and the one that came out in the big review by Shakel about 10 years ago now, but it's still much the same, is that it's essentially to optimize basic procedures, the central line in bundles, a lot of the infection control, the surgical safety checklists, all the sort of checklists. They're all basically about improving reliability. And the broad approach to implement this it's essentially a quality improvement style of intervention. Now, some people will say, oh, well, this is all very mundane and you should ignore it. I think personally, these approaches are very, very important, but they've been rather overemphasized, if you like, as the sole approach to improving safety or quality. But that's one very big approach, and it's very commonly one. Probably particularly important as a foundation in low resource settings. This is a paper that you can follow up later if you want, but one of the most important things when you don't have any resource is to decide on a few of the basics. What is really safety critical in this setting? So it's, in this case, it's a Kenyan neonatal unit, pediatric. So, disinfection, documentation, certain types of assessment of the babies coming through are very, very critical and need to be prioritized, and rather than having a more scattered and fragmented approach. So this approach is very, very critical in certain respects. But a very different approach is not to think about particular processes, but to take the lessons of safety from the time of Jim Reason, 1990s, and think about the system. And oddly, although all the rhetoric of safety is about systems, not so many of the interventions have actually been about improving the overall system. And these are things like standardization and simplification of processes, automation, equipment design, certain aspects of teamwork. Who's responsible for what? Very basic things that can actually, can certainly kill people to get this wrong. And that kind of thing. So in the context of a low resource setting, these are, maybe introducing very straightforward tools like whiteboards and, things that are routine in modern, emergency departments in our countries, in the US and so on. Defining tasks, team basic organization of things, establishing joint handovers, nursing records and so on. These are very straight basic things, if you like, but very, very important in these settings. And this is all going to improve efficiency, safety, quality. These are optimizing strategies. To give you an example of approach, something that might be important for us and is still important and relevant, I think, in the decluttering that Rebecca Lawton's group are doing at Leeds, is the number of procedures we have. When I worked at Imperial, we did a project. I became very interested in the number of guidelines and procedures the staff had to follow. Seems like a rather dull topic, and in some ways it is. But we got together a small group one day, and I said, well, how many procedures are there? You know, and it was just an impossible question, but we took the first 24 hours of an elective hip operation. And we just said, well, how many procedures are in the first 24 hours? So you can privately guess, but I'll tell you that there were probably more now, 75 different procedures in the first 24 hours that the staff were meant to follow. It was absolute madness. And of course, many of them conflict. So this is one of the reasons when you get instant analysis, incident reports, often they'll say that the staff didn't follow the procedures. Well, when you look at this, you can understand why, that there may be multiple reasons for not following procedures. So all this is sort of optimizing processes, optimizing the approach, but also improving safety. So that's the second family of strategies. Now here's a third one, which is very, very important in other industries. I know this mostly from René, who's worked in aviation a lot, and oil, and many other in different settings. And this is the approach of controlling risk. And, you know, you can stop, we can't stop care in the same way that you can stop oil production or something like that. But they do all sorts of things to place restrictions on where things are done, on who is doing them. The conditions of operation, whether you've got the right equipment in place, determines whether you're willing to start something or not. And a very kind of clear set of boundaries around different activities. This is something I think we're quite weak on in healthcare. There are certain things, mostly about medicines, I think, where there are very clear boundaries and guidelines, you know, which are enforced. Some of them are legal boundaries, but also it's, you know, a question of grade and experience about what you are and aren't able to prescribe. But there are certain areas where we could do a lot more. And I'm not talking about, you know, huge regulatory interventions or something, but just something that can be a much more agreed clinically or by a professional organization. For instance, I mentioned earlier that many surgical operations start without all the equipment being in place or with broken equipment. As a patient, you might think that wasn't ideal and, you know, maybe they should have everything in place before they start. And clearly there are many reasons for it. I'm not blaming the operating theatre teams, it's procurement and all sorts of other problems with the NHS. It is clear, this is a study from a few years ago by Paul Grieg and colleagues. This is about whether anaesthetists these experienced anaesthetists are willing to start operations with faulty equipment. In this case, it's not a functioning oxygen monitor. And we had about 20 other examples where what people say, and this is just two quotes. One from somebody saying that he's well aware that a functioning oxygen monitor is present in the guidelines. The council of perfection, he calls it, or she calls it, we don't know. But basically they're saying, well, you know, I know how to manage this without a functioning oxygen monitor. I think we should get on with it. This completely opposite view about this person saying they wouldn't proceed. There's a risk of awareness and hypoxia. And as they say, it fails my stand-up in court test. So wildly different views from experienced anaesthetists around the Oxford area. Now, the risk control, we could talk about this in terms of individual decision-making, but a risk control would be to agree in that department or in that profession about the conditions, what you actually need to start an operation, and under what circumstances you should, you know, pause, halt, wait till you've got the right equipment, rather than just leaving it to individual variation. So that's one example. Here's another example from Kenya, and I won't talk to you about this in detail, I'll just explain the principles. There's a lot of very well-intentioned equipment and processes going into these settings. There's all sorts of problems, though, about putting quite sophisticated procedures and processes and equipment into settings which don't actually have the resources to deal with it. So this continuous positive airway pressure is a really useful approach for helping a sick baby with severe respiratory distress. But it does require monitoring every 2 hours and some expertise and, really quite a lot of attention to the young baby. If you can't do that, then it's actually quite a dangerous procedure if you can't monitor properly. So if the unit starts the baby but then is unable to monitor sufficiently afterwards, then it does more harm than good. So the risk control approach would be to establish the circumstances under which it's reasonable to use these sort of approaches. Yes, it's rules, yes, it's regulation, but it's a safety intervention, and it's in the best interest of the various patients, in this case, whether it's in the UK or Kenya, that to have these sort of understandings and rules, if you like. So that's risk control. Another approach, which perhaps we're more familiar with, I'll go through more quickly because I think it's more familiar to you, and also it's a bit relevant in the second part of the talk. And this is perhaps the territory of people who are interested in resilience. So to me, resilience is one approach and one thing we need, rather than the sort of vision of the whole system, which I know people have different views on. But it's essentially that every system, some more than others, obviously a very standardized and organized system requires less of this than a very fluid system. But safety is also achieved in this fourth, very different way, about people being able to monitor hazards, adapt quickly, respond to emerging problems, whatever they may be, equipment breakdowns or missing staff, or sudden changes in the patient's condition or whatever. And René's earlier work in aviation pointed out that fighter pilots, even where you might think they're fantastically good at sort of improvising on the spot and that, but actually there's a huge amount of anticipation going, a huge amount of preparation of what if, and trying to build in the preparation and the adaptation, if you like, from the start, rather than just sort of hoping to be brilliant at the time. And you can see this, and this is a quote from a surgeon, having a strategy ready when there's bleeding, hold automatic responses to a hazardous situation ingrained in your mind so it can be done without stress and strain. And she talks about the groin bleeding and rehearsing her junior surgeons over and over again, so that when it happens, they just go into autopilot. I remember being very surprised in Bureau, I don't know what it's like when I went to work in surgery, of how little their training was focused on what to do when things went wrong, as opposed to learning, how to do it right. I think that's changed quite a bit over time. But also you can build this sort of thing into your safety program, into organization, by creating time and space for these sort of informal, perhaps, but creating time for people to monitor, to check with each other, and also to develop through simulations or whatever, planned approaches to dealing with hazards and so on. I could talk a lot about this, but you'll see that for me, a lot of the briefings and debriefings and certain types of team training fall into this. It's not a specific intervention to do something. It's creating the space and the time for teams and individuals to monitor safety, to interact with each other. This was probably much more present informally in earlier times without quite such pressures. But when at times of great pressure, as we'll see, it's particularly important to preserve these things, these possibilities, in order to preserve safety. The final, this is a big topic, but the final category, if you like, the longer term ones, is mitigation. This is after the event. I've always been very concerned with the support for patients, families, and carers. And it's really great that, you know, work of Jane O'Hara and lots of other people, Tom Gallagher in the US, and it's very slowly gaining traction. And of course, there's support for staff. But mitigation, actually planning ahead for when things go wrong, rather than just, again, improvising the time, I think is a really important safety strategy. It's not used enough. And here's a very nice example of a dialysis program. This is Paulie et al. About 8 years ago, this was published. This is it's quite commonplace, obviously, that people manage their own dialysis at home, or they come into sort of out of hospital places to do dialysis in groups, or there's various ways of doing it. What's interesting about this program is that they didn't just teach the patients to do the dialysis, they also taught them about what to do when things went wrong. So it's partly anticipation and the monitoring and so on, but also explicit methods, you know, letters to the emergency department, instructions to what to do. Dialysis seems, as far as I can make out, to be pretty safe at home nowadays, but there have been quite a number of instances of people harming themselves seriously and some deaths. So it's not, and there are disconnection possibilities also, and, you know, connecting the wrong thing and all sorts of the usual sorts of problems. So they taught the patients and their families, I think, about all these issues. They taught them, if you like, a basic safety procedure. So that's, I thought, was a very enlightened approach, and one, as we move more into thinking about home care, is going to be increasingly important for training for safety for patients, which I and many other people are beginning to worry about. So that's the long-term approach. And I just want to sketch to you what I think we now need, which is to think about adaptive safety strategies for the short term. Because, well, for many reasons, partly because, as everybody knows, the healthcare systems everywhere are under a lot of pressure. But also because the longer term approaches, which we've, you know, worked on for 20 years in different ways, are easily derailed by pressures. So the classic thing that during COVID was that people closed their safety and quality improvement units, or, you know, put all the staff on the front line. So, I mean, in retrospect, I think it was a fairly disastrous sort of strategy, because they were just deployed into kind of ordinary role. But as everybody will all know, of course, people say, well, you know, we'd like to do more improvement, we'd like to do more long-term safety, but, you know, we've just got to concentrate on the short-term pressures. Constantly, of course, things don't improve because of the short-term pressure. But it is obviously reasonable. People have to deal with short-term pressure all the time. And increasingly, this is a problem, not just in the NHS, but in many countries. So we started to think, initially, Renee and I, again, this is a paper from, I should say, wanted to point out, it's pre-COVID. So we didn't know about COVID when we wrote this paper. We were writing about the increasing pressures on systems, the reality, and the way performance of an organization or a ward or a unit, whatever, drifted in response to pressure, which has been described a lot, mainly in terms of monitoring the signs. But we started to ask, well, okay, what strategies are available for dealing with pressures? And particularly, can we train people? Can people learn? Obviously, you know, any experienced manager, any experienced clinician has their own approach to dealing with, you know, pressures and times. But it's a question about whether we could identify something that people could learn, whether some ways were better than others. And I vividly remember always that when I was at Imperial, the head of the emergency department, I used to talk to quite a bit, and I asked her one day, when there's a train crash, a big set of, you know, problems, what do? They obviously have to adjust the way the emergency department runs when they're under a lot of pressure. And she said, well, we do, but everyone does it in a different way. And that remark always stayed with me. There was no coordinated approach to dealing with this, no planned adaptation. So I'm just going to try and take another, say, 5-8 minutes to sketch some of this, what we're trying to do at the moment. We can obviously pick this up in the discussion. So I'll do these last 10 or so slides reasonably quickly. This is the first paper that made the argument for it. We've recently published this one. This is Beth and Page is leading this, where we took the, this is a scoping review. And what we did was we tried to find papers where clinicians had been interviewed about how they responded under pressure. Now, this wasn't, and what we were interested in was particularly, well, what do people actually do? And the way we did this was to look at, to find studies that had actually been studies aiming to explore resilience. But we didn't want to get too embroiled in the theory of resilience. So we didn't actually look at their findings, because most of the papers used the findings to confirm, that resilience was important and confirm the ideas of resilience. What we did was we just looked at the results sections and we tried to extract, without worrying about whether it was resilient, whatever it was. What are actually people doing? And from this, we started to get this sort of picture, sort of hopefully what I hope will become a simple picture in time, because that's always the success of a framework. It's got an undying simplicity. So they break down really. Firstly, people start to talk about the pressures in these various papers. I'll come on to some interviews we've done ourselves in a minute. And then there are certain types of anticipatory strategies. And I'm not talking about long-term, just thinking about planning for next week or next month. And then there are things people do on the day to flex and adjust, often quite drastic things that I think we need to understand a lot more of. And from this, we produce, which I won't, this is in the paper, you can call it up and look at it. The pressures, and which I'll talk about a bit more about the way people describe this, and then the different types of adaptation. And you can break them down, actually. You can begin to form a conceptual framework here. That there's various ways of increasing resources, often temporarily, this is, not talking about long-term here, restricting demands in various ways, and adapting ways of working or managing the work. You can do this in anticipation, certain things you do. Then there's various versions of this people use on the day. So let me just try and sketch a little bit to give you a flavor of it. So in surgery, and we did interviews in surgery and intensive care, 20 clinicians of different levels and types in each. And as you can see here, and again, I'll apologize for doing this rather quickly here, but you get the various problems of high patient numbers, staff shortages, skill mix, all the classic stuff. Basically, it's demand exceeding capacity is the biggest problem. Obviously, there are many other safety issues as well on the back of this, but this is the key thing. This causes high workload, you get less supervision, then it got, obviously all sorts of effects on teamwork and so on. And this in turn starts to produce problems with the system functioning, because then you get delays in patient flow, delays, lack of buffer for anything unexpected, lack of communication. And this all starts to feed back in a vicious feedback loop, to create more demand that exceeds the current capacity. So it's quite a complex and fluid situation when the pressure starts building up. And this is, of course, everyday stuff. There's a lot of literature on, managing the unexpected and unexpected pressures and surprise events. But actually, these events are no longer a surprise. This is a permanent situation now. That's the difference. This is an interesting quote. One of the things we asked them was, what's your main objective under pressure? And this person says, it's a really good question, because I could very easily say patient safety, but you can't. This is an important shift, I think. What's the main objective? We have to manage the risk to the best of our ability. That's the main objective, I think. It's risk management. You can't walk around being risk averse, because obviously risk has gone up, hasn't it? So it's risk reduction as much as you possibly can. Now, when I started working on what we now call patient safety, we used the term risk management. And Renee and I, we called our book deliberately Safer Healthcare, because I think more and more, I think that actually returning to the phrase of risk management is much more true to what's actually going on and probably what we actually need to do. And perhaps to distinguish it also from the sort of more quality optimizing approaches, but we can discuss them. So very quickly, the strategies in the ICU, just to give you a flavor. You can actually start to map these out, and there are certain ones here, improving the skill mix in anticipation. They try and look at various ways of upskilling their healthcare assistants. Sometimes this is longer term, but often it's just the week before, about trying to kind of give them additional responsibilities. Controlling demand, discharge policies, these start to shift quite drastically. We heard quite a lot. I didn't really know about. I was assumed myself, and I think that people are discharged from intensive care back into a ward or to a step-down unit. But people are being discharged home from intensive care, which I think, as some of the staff said themselves, and I've never heard of it. This is only recent. In my career, we haven't been doing this. And adjusting the sort of expectations, basically running what they call a Christmas Day service or planning for that, on all sorts of times of the year. And in ICU particularly, they do a huge amount of flexing on the day. This is rather different from surgery, which is much more about sort of plan and cancellations and so on. And they have an education team who they just sort of shift onto the ward. So the education stops and they have to move into patients. They do a lot of prioritizing, not keeping people out of ICU, but basically reducing the amount of care, not turning patients so often, stretching the intervals of things, delaying things. So there's a big kind of stretch on the way care is delivered, not surprisingly. And you can think of this as work missed, which is a lot of the nursing literature talks about, but you can also think about it as, well, what's the best strategy? You've only got so much time. Maybe it's better to decide what you're going to do and what you're not going to do. And a lot of use of, I think, the smart units, if you like, have more huddles when things are tough. They may be very short, but they make sure they have them. Now, there's a lot of, I won't go through these again, but just to say we can draw up quite a long list of these sorts of strategies that people do. We don't know their effectiveness, and some of them obviously have adverse effects as well. But we can begin to actually quite clearly identify a set of things that can be done for good or ill in these situations that stretch and bend care. Their impact on patients is going to be highly variable, I should think. So I'm going to skip the slides here. It's a comparison just for the time to make sure I finish. We are concerned with, it was perfectly clear that nobody had ever, in the interviews, that people actually found the interviews very interesting. They seemed to enjoy them a lot. And as you might expect, they said, well, we do all these things, but obviously we've learned them just from experience or from people had hardly ever received any training or teaching. In fact, quite some very interesting comments made about NHS leadership courses. And they said, well, no one's on any leadership course I've ever been on. No one has even ever mentioned this kind of thing. So it does make me think that maybe there's a need for this sort of thing. And that we maybe want something the PSRCs might be interested in to say, well, how are we going to teach people to adapt and work under pressure? I'm not suggesting that the things I'm talking about are the only things we need, but you can begin to imagine what kind of program might look like. So finally, in the last minute, I'm going to just flash a couple of slides to give you a general sense, again, which are available and can be looked at. So we now have the possibilities of combining the short and the long-term strategies. In the paper we have here, the systematic review, we managed to summarize the anticipatory strategies and the on the day. It's a complicated diagram, but I wanted to show you the overall picture rather than the detail of this. And as you see on the anticipatory, there are resource strategies, various ways of managing workload, coordinating things, different things people do when the pressure is high. And there are a huge number of things people do on the day, which are basically a big flex of the way you do things when there are enough staff and you can run everything in a more orderly manner. And the different styles of communication. This is not just the standard safety stuff, but adaptations at the time, right? Of leadership, communication, teamwork, and all sorts of things. And alongside that, I think I would like to say we still need to think about these longer term strategies. And I'm suggested to you that it's helpful to think about these families of strategies when you're thinking about a research project or an implementation, these are broad ways that one can approach things, either to optimize care in the kind of classic manner, or to think more about managing the risk, which I think can emerge very strongly from the recent interviews and the sort of current situation that maybe risk management is in some respects a more accurate description of what's going on than patient safety as a term. So I think I should stop there. I hope I haven't run on, Debbie, I've run on maybe 5 minutes, but hopefully that's okay. Right. What's the share?
Thank you ever so much, Charles, for that thought-provoking overview and the questions for the future of strategies. And also from a personal perspective, just thinking about how those list of strategies might look when staff are out and about in the community and in people's homes, and the things that they have to do to flex and adapt, especially on the day to unexpected conditions.
Yeah.
But we have an opportunity for some questions. So there are 2 ways of asking questions. One has been to put questions in the Q&A box, which we have one that Debbie will put to Charles now. However, if people do have questions, please raise your hand, and then our fabulous administration team will be able to give you the permission to speak. So that sounds a bit over formal, but it's the best way of doing it. So please, while Debbie puts the question in the chat to Charles, please do raise your hands and we'll enable you to ask.
Shall I start with Rebecca's question in the chat?
Yeah, that would be great, Charles. Thank you.
Oh, thank you, Charles.
Yeah, no, that's great, Rebecca. Which is the best approach? I think the short answer.
Sorry, Charles. I don't know if everybody else can see that question.
Okay.
I don't know if it's only visible to us. So
might be best reading it out then, Debbie, please.
Yeah. So Rebecca makes a comment, obviously thanking Charles for the presentation, but was very interested in the idea of agreeing a go, no-go criteria in advance, thinking that some staff will take risks and others are extremely risk avoidant. And Rebecca's question really is around, when we're agreeing on the approach, is it best, and do we tend to sometimes veer towards being risk averse when something is formalised, because it doesn't seem appropriate to try and not to reduce risk to zero?
Okay, I think this is a great question, and I think the first thing to say is that the question really is, it's true that some people are risk averse and risk avoidant, or I'm not saying this is a personality characteristic, but it's certainly very hugely variable according to the situation. And I suppose in other industries, people might take the view that it was extremely undesirable to decide these things on the basis of an individual's personal risk tolerance. And if we ran aviation like that, it would be, I don't think it would be anything like as safe as it is now. And if we put in some sort of rules and agreed procedures about, you're essentially saying it would be safer to institutionalize some arrangement than to rely on individuals' judgment. Now, where you set that bar is not so straightforward. And I absolutely agree, it should not be, risk, you can't aim to kind of have no risk at all. But I imagine that, a group of anaesthetists could say, well, in almost all situations, you should not start an operation without following list of equipment. And always, I think, especially in healthcare, you need an override. You need a situation you say, yes, but if the anaesthetist really says, no, we need to get on with this, that's okay. You can override. But, you know, there are systems you can override as long as you write down your reasons. It's usually the sort of typical thing, because at least it makes people think about it, and it gives a default. And the other reason for having rules of this kind, I think, is that one of the reasons the equipment continues to fail to turn up is because people are willing to wing it. And although it's one of these situations where the actions of an individual clinician in the best interests of one patient, the patient in front of them, are actually highly detrimental to all the patients that follows. So there's no system pressure because clinicians are willing to, through best intention, to operate in very adverse conditions. I've come to think this a lot over the years, that the willingness of the great value, one of the values clinicians have is that you can cope with a lot that's thrown at you and you can cope. And of course, that's fantastic. I admire it. But the downside is that they cope with things, rubbish systems, and so the rubbish systems don't change. And I think this is the sort of situation we have that, you know. I mean, when somebody who's an engineer comes in and looks at operations starting without, you know, it just seems extraordinary. Sorry, there are more questions.
There are more questions, and I think people can see them, but I'll just read them out just in case they can't. So a question from Peter Gardner. Thanks, Charles, for a very interesting presentation. Much of what you've talked about seems to be hospital-centric, but a lot of healthcare now takes place in the home. Are the key issues the same in this environment?
Well, thank you. That's a great question. And it's perfectly true that a lot of it's, well, all our work actually, I don't mean me, but just all of us in patient safety, is a lot of it's been in the hospital. And Beth and I and others are very interested in the home. And I think, yes, broadly speaking, it'd be silly to say I don't see the home as any different from hospital, because obviously it's very different in multiple respects. But I see the same sorts of things, if you like. I think often we as family members, patients, we have our own safety strategies of different kinds. People do build in all sorts of routines to manage things safe. I remember Jane Carthy, who's a great human factors person, who she's talked about this publicly, used to look after her mother-in-law, who was had various all sorts of mental health problems. And remember her talking about all the strategies that she and her partner had developed to manage her mother's care. And they were quite sort of formalized and developed. And I think we're going to have to, as patients and carers, we're going to have to learn a lot more about how to manage healthcare and how to do clinical tasks. So we're going to have all of those things. I'm not sure all the strategies, we may certainly have to have strategies working under pressure. So I'm not sure we can institute all these sort of approaches in the home, but watch this space, I think. But I do feel, broadly speaking, we have to, as Beth and I have discussed, we have to treat the home now as a healthcare environment and think about all the things we've thought about, you know, the environment, regulatory approaches, you know, working conditions. All these things are going to be highly relevant to how safe care is and whether the home is a good thing for people, which obviously it is in many ways, or whether there are going to be safety problems.
Thank you, Charles. And that probably nicely brings us on to our final question, I think, for the session. This question is from Nick Bodie, who, again, thanks you for the talk, and asks if you specifically looked at the safety of transitions between hospital, primary care, general practice, particularly as the receiving end, general practice, is so heterogenic. Any thoughts on improving safety in the context of such heterogeneity?
I haven't worked a lot in general practice, a little bit. So I'm not sure I've got anything very. I think in the time available and I can only answer this very briefly. I suppose one thing is I'd be trying to simplify always I'd be trying to simplify the situation as much as possible. I know you can't reduce the heterogeneity of the patients, but you can sometimes reduce the heterogeneity of the approaches taken within a practice or across practices. And that in itself helps a lot, not having different procedures across different practices and trying to kind of agree things. I suppose it's the other aspect is to use the different families of strategies to think through what's going to be helpful in this particular situation. We probably can't do a classic quality improvement. What kind of system improvement? We've got a lot of options of system improvement. Can we think about those? Or do we have to enhance the possibilities? I mean, one approach to general practice is very important, for instance, is when you've got a very fluid and uncertain situation, you don't know whether the patient's going to come back and all sorts of things, is to not so much to make things safer, but to improve error detection or to improve things when things go missing and put in more follow-ups, more safety net procedures. So they're thinking very broadly about different types of approach to safety is very important in these things. And I think, as somebody said earlier, not trying to make things perfect is also a very good approach in these kind of settings, and trying to think about how to make things a bit safer than they are now.
So thank you very much for that, Charles. And I'm sure you will all join me in thanking Charles for giving this first in the series of safety net seminars. We've come to the end of our time. I'm sure if there are questions that you haven't had an opportunity to ask, then if you wanted to email them through to our team, then they would be delighted to forward them on to Charles, and I'm sure Charles would be equally delighted to provide some answers to them. So what remains is just to thank all the attendees for their time today, and we hope you'll be able to join us for future seminars in this particular series. So it's goodbye from the team. Thank you.